Pleasure to be here with you all. Thank you very much. I want to thank John Braheny for this great conference, for the organizing committee, and for you all for being here. It really is humbling to be here. I have no disclosures. So I heard once that to make a good talk, you should tell them what you're going to tell them, and then tell them what you told them. So good ethics is good medicine. Thank you. It was a great talk. My hope of this talk is to really start with and end with this message that if you're going to try to do fertility care services in academics or build a practice or talk to patients, that you really have to have this as the core of what drives you, and you have to believe it because it's true. That good ethics really is good medicine. That we're offering the best care to patients. We're not offering suboptimal medicine. We're offering good medicine for patients, giving good care to patients, and this should drive the way you talk to patients, talk to colleagues, talk to administrators, marketing, all of that. Okay, the rest of what we talk about in this talk, I hope, will help flush that out or reinforce that, but that is the message I hope to really convey. So Catholic healthcare, what is that, right? The impression is, we even talk about it in the way that to do Catholic healthcare, it's a list of the things that we do not do. Catholic healthcare is about not prescribing contraception, not doing abortion, not promoting premarital sex, not doing sterilizations. But I hope to change that paradigm, change that way of thinking. So I think Steve is here, Steve Hilgers. And he asked me last night, how did I get into this work? And I didn't have a chance to answer him, so I'm going to answer and tell you all. Everybody has their story, so this is my story. I was leaving seminary to go and begin medical school. At the same time, a friend of mine who was a practicing family practice doc was joining that same seminary. And he sent me a letter and wrote to me, kind of just a cordial letter, and in the envelope was a pamphlet. He didn't mention the pamphlet at all. This is Father Joseph Tam now. It was just there. And the title of the pamphlet was, "Can a Catholic be an obstetrician gynecologist?" And that question stuck out to me. That was the question. How do you be an OBGYN and Catholic when it's all about what you cannot do? And the pamphlet was written by Dr. Hilgers, and he talked all about how Catholic healthcare should not just be defined by what you cannot do, and it should be all about what you can do. And he talked about working with the woman's natural cycles and restoring those cycles and restoring the woman's natural ecosystem. I mean, these kinds of terms and ideas that blew me away. It was really mind-blowing. And it was really a paradigm shift. And I called him the next day and I said, I read this pamphlet, I want to come work with you. I've been there 3 times, we have published together. But that was the start of this paradigm shift. And really Catholic healthcare, I hope you can see, should all be about what we can do and not just what we cannot do. And I think Humanae Vitae drove us in that direction. So I am not a big fan of this term NFP-only physician. That means that the implication, or it kind of sounds like, you're a physician who doesn't do abortion, doesn't do sterilization, doesn't do contraception. It's not defining you on what you do, it's what you don't do. And then we almost get embarrassed even sometimes, like we're kind of left with whatever it is Catholic healthcare is supposed to be. So I try to be mindful of trying to use the term fertility care physician, maybe an alternative. Maybe it'll catch on or whatever. But it hopefully describes that I can, as a physician, provide for patients and deal with women's health issues and infertility, that cares for their fertility and maybe even improves or restore their fertility. Okay, so Humanae Vitae, as we all know, did reinforce or reiterate that you cannot divide these two ends. So you can call it I mean, it is called the unitive and the procreative ends, but maybe, talking to patients, love and life or babies and bonding, and you cannot have one without the other. So if you have babies without bonding, that's in vitro fertilization. And I love the way John Paul II talks about it. He says every baby has the right to be born directly out of an act of love. If you try to go the other way, bonding without babies, that is contraception. So that's maybe just a simple way to think about it. What happened in every other field of medicine, we're taught to find the problem and fix it. Somehow in the worlds of women's health, we either use suppressive therapy, like Dr. Hildreth said last night. If you're going to be a run-of-the-mill OBGYN, it would actually be very boring. You prescribe contraception or birth control pills for everything. And then now we have this huge multi-million-dollar industry, which is to try to treat infertility, not by treating the root causes, but by bypassing it. So we've lost really the heart of medicine, which is to find the problem and fix it. Even beyond the ethics. So Humanae Vitae talked about what we should not do and not divide these two ends, and what would happen if we did that. It was kind of prophetic. That was 50 years ago. Now, 50 years later, we can talk about what has happened. And I think we'll all agree, and I'll try to rush through this here, but the Me Too movement, disregard for women's well-being, sex trafficking is hugely on the rise. Coercive use of contraceptive methods by governments. China as the one-child policy is a great example. Treating our bodies like machines. Surrogate motherhood. So contraception and abortion are roots of the same tree. And even in the legal arguments that led to the legalization of abortion in this country, one of the main legal arguments was, we know that contraception fails. Even if used perfectly, there's a known failure rate. So you have to help couples deal with that when it fails. So because of that, we have to offer abortion. That was a primary legal argument, as I understand it, in Roe v. Wade. So they're very much linked. So to talk about alternatives or a different way to family plan outside of contraception, it's actually a very good time to be able to do that. I think our predecessors have maybe had a harder time, but now it's very trendy, okay? Here's something I pulled up online, why women are ditching the pill for the fertility awareness method. Top five reasons women are ditching the pill for fertility awareness methods. And this is not from, I think this was actually from a secular website. It works, no side effects, cost-free, body knowledge, empowerment. What a great word these days, right? Empowerment for the woman. It's a knowledge-based method. The woman learns about her body, and she can use that knowledge to either achieve or avoid pregnancy. So in that way, it's a true method of family planning. It's not just to avoid. Ricki Lake. Anybody heard of Ricki Lake? She did a documentary on alternatives to birthing. I think it was really mainly on home birth. She now has done a kind of a GYN side documentary or project called Sweetening the Pill. She has no religious reason to be interested in drug-free methods for family planning, as far as I understand. But she and others are interested in doing that or looking for alternatives because they're worried about what the hormones are doing to the environment. They're not thrilled with the idea of flooding the woman's body with hormones that mimic a chemical pregnancy and all the side effects and harms that can happen to a body when that happens, especially over a long period of time. So that's out there. Oh, sorry. Okay, this is from CNN. It's been in the secular news. It's very trendy to talk about fertility awareness-based methods, or for birth control, what's old is now new again. And it's not just rhythm, as was mentioned before. Well, maybe I should do this. Okay. I do want to proceed. Here, there's all kinds of different apps and things. So it's very trendy to talk about FAM or FABM, fertility awareness-based methods, with patients, with other people. It's very trendy to be organic or drug-free. All kinds of magazines are devoted solely to being organic and drug-free. Even our American College of OBGYN, ACOG, this to me is amazing, and that's our national organization of OBGYNs, who are in no way really, they're very promoting of contraception and abortion, and even mandating referrals to abortion, for example. They have produced a patient education pamphlet on fertility awareness-based methods. This is amazing. Even they are on board. They know that it's out there. Okay, so again, I don't really, in medical circles, often use the term NFP. I try to avoid that. I like to use the term fertility awareness-based methods. Okay, it's true family planning to either achieve or avoid pregnancy. The quote-unquote Bible of contraception in terms of effectiveness, because this is really important when you talk to people, is contraceptive technology. And in their latest edition, as I have seen it, they do talk about fertility awareness-based methods, FAM. Now, in any, or whenever you talk about the effectiveness of any birth control method, you can talk about method effectiveness or use effectiveness, meaning how effective is it when it's used as it's supposed to a T, basically. Like if you're taking a pill, do you take it every day at the same time like you're supposed to? And then what is the use effectiveness? So even in contraceptive technology, they have written down and published that the method effectiveness of FAM methods are between 95 and 97%. Now the use effectiveness they would say is 75%, and other places have said that there's a 25% failure rate. Use effective for FAMs, and a lot of us would disagree with that. But at least they have this there. It is an educational model. You have to use it well. It does take some motivation, but when used properly, it can be very effective. This is as effective as the pill. So, NAPRO technology, or what has grown out of this standardized method of fertility awareness, the Creighton model system, is this approach we know as NAPRO technology, to evaluate and treat the cycles and to support them properly timed to the cycle. When you look at a cycle, when they teach these methods to third world countries, for example, they talk about seasons, which I think is a great way to talk about it. But when you look at a chart like this, the seasons are all messed up. And very quickly you can get a lot of information about what is happening or what is wrong with the cycle. And then this approach has also led to this whole approach to infertility without IVF. So infertility is huge. 1 in 6 couples, at least 1 in 10, I think in some studies or some places I've even read 1 in 6, couples deal with infertility, which is huge. If you go to an infertility specialist, kind of a contemporary infertility specialist, a lot of the treatments, so to speak, quote unquote, that they offer, it's a whole letter alphabet soup of options for you, right? IUI, IVF, ART, IC, SI, all this stuff, ICSI. So, but they all kind of are trying to achieve a pregnancy by bypassing things. So IUI bypasses cervical factor. IVF bypasses the couple altogether to create the baby and bypasses the marital embrace. And when you talk to patients, when I talk to patients in the office, I say, we do not offer IVF. We offer an approach where we're trying to find the problem and fix it, to help you get pregnant together as a couple. In doing so, by looking for the underlying issues, we're going to find some answers, hopefully. Hopefully, in treating the underlying conditions, we help you feel better, and I believe there's a direct correlation between feeling better and chances of pregnancy. It's billable because we're billing underlying diagnoses, and it can lead to ongoing fertility. And when you talk to patients like that, they really respond, and their eyes light up. And again, they're like, why haven't we heard about this elsewhere? But on a human level, people want answers, and on a human level, if possible, they would love to have a baby as the result of the marital embrace. I once saw this on Instagram, which I think really highlights the experience of a lot of women who go through ART, or artificial reproductive technologies. For a lot of women, it is not fun. Maybe you get a baby at the end, but the treatments and the side effects of all the treatments that they're getting are not in any way natural or restoring of the woman's natural ecosystem in any way. It's hyperstimulation, creating 16, 18 follicles, sucking out the eggs and all of this. They actually give you Lupron, which is a medication to induce chemical menopause, to shut down the system completely, the natural system, the woman's natural system, and then give you back all the hormones to create a completely artificial ovulation. It is really amazing. When you talk to colleagues, administrators, in medical circles, and I have put some websites on there too, but there's a recognized need for alternatives to IVF, not just ethically, but on many other levels. There's side effects of medication, there's the issue with multiple gestation, prematurity, low birth weight. Birth defects has been well documented, is higher in babies born from IVF. The issue of excess embryos, and cost. There's no mention of ethics here at all. There's a general awareness of the need for alternatives to IVF. And then when you talk to patients, they understand that there's an issue with bypassing the couple. Here's an article showing that there was an increased rate of birth defects in babies born from IVF, or ICSI. So we have this alternative. So NAPRO technology, not everybody understands, but it's meant to be the alternative to artificial reproductive technologies. We have natural procreative technologies. So, and again, this approach is a disease-based approach. So when I talk to students or residents or even colleagues, I say, this may not be, at least some of the protocols or some of the things, evidence-based, but it's definitely disease-based and biological. And the next step is, and that's how often the field of medicine moves forward. You have some experience, it does make sense, it's disease-based or biologically based, and then you take the next step to then validate that through research and publication. I have always felt called to academics because I have seen myself called to that next step. Dr. Hildreth is the pioneer. He has given us, and there's I think a second version coming out, this textbook called The Medical and Surgical Practice of NAPRO Technology. Before, when you did the EP1 and EP2, you were given a 3-inch binder, maybe several, with all of these articles. Now we have this nice, maybe still be 3 inches, but textbook where it's all in one place. And this is a great launching pad now for validating the protocols and bringing it back to mainstream. If it is true and it works, and it's true in accordance with the way that we're supposed to be designed, then it should work, and we should be able to validate it. And I have felt myself called in that direction to research it and to teach from research and publication and to teach the next generation. So these are real solutions to real problems. How effective is it? Just like you have to talk about how effective is FABMs for avoiding pregnancy, you have to talk about how effective is NAPRO technology or any kind of restorative fertility clinic for fertility. So IVF clinics are mandated to publish their success rates to the CDC. So the average success rate for any IVF center is about 30%. When you talk about success rates for NAPRO technology, you can now not just talk about an overall success rate, which you can, but in addition, you can actually give a disease-specific success rate which is much more informative. So for anovulation, it's at 80%, PCOS, 62%. I think that's actually kind of low. Endometriosis, 60%. Even that I would say is low. There are publications looking at the effectiveness for fertility now of treating stage 4 endo, which is the worst kind of advanced endometriosis, even requiring a bowel resection, showing that the rate of fertility or pregnancy after dealing with stage 4 endo with a bowel resection is up to 60% in 1 to 2 years. I think that's fantastic. It may not be right away, but the patient's going to feel better and over time has an excellent success rate. And even if they decide to choose IVF later, they really haven't lost much in terms of the potential success rates for IVF. But at least they've had the underlying condition treated with good success rates. They often feel better. They get answers. And women want answers. If you've dealt with infertility, my wife and I dealt with some infertility, women want answers. It's not adequate or satisfactory to tell a woman, we don't really know why you're not getting pregnant, but we can bypass everything and do IVF instead. Patients want answers. But the success rates when you deal with the underlying condition are very good, and even advanced endo can be quite good. And those studies are not by NAPRO clinics. Those are done by just people who are excising and treating endo. And I think the success rates can be even better when you combine the non-surgical optimization for fertility as well. So I was taught to think about infertility in 5 factors. And so this is how I even talk to patients about it. Male factor, female factor, cervical factor, sexual factor, anatomical factor. Well, we explain to patients that we're trying to restore and work with the natural cycles of the woman. We work with patients who chart their fertility. And the charting helps at least 4 out of 5 of these factors. And all of the factors that deal on the woman's side. Can we help male factor? Yes, absolutely. But we need the charting to help with the female side and the female related factors. So it helps us time the hormonal measurement and support of the hormones when needed. It helps us identify the cervical mucus cycle and give a score for that cycle. It helps us time intercourse and do what's called fertility-focused intercourse. And you can pick up a lot of abnormalities in the charting that can come from structural or anatomical issues like endometriosis or endometriomas, which are balls of endometriosis in the ovary. This is a great study, I think. This is a study of couples who met the definition of infertility. So they have gone a year without getting pregnant and without avoiding pregnancy or of trying, okay? And all they did was learn to chart, identify the fertile window, and target intercourse or the marital embrace to that time. So we call that fertility-focused intercourse. Just with FFI, in couples with infertility, the rate of pregnancy was between 20 and 40% in 6 to 12 months. That's as good as IVF in under a year, doing nothing but FFI. And when you add to that other optimization, hormonal and or surgical, again, it's up to 80%. This is tremendous. We're not offering suboptimal medicine. This works, patients feel better, they're getting answers, it's billable, and it can lead to recurring fertility. We're cooperating with the hormones. This is what the hormones look like in a normal cycle or a normal chart that has normal seasons. When it's abnormal, it can be picked up in the chart. This is just to say, this is 3 consecutive cycles of the same woman. The cycle changes. If you're going to try to measure progesterone, you need to measure it 7 days after the day of ovulation or the peak day in charting terms. You can see that it would vary. You would hit it at the right time or not depending upon that cycle. And again, this is 3 different consecutive cycles in the same woman. So you need a way to know where they are in that cycle at the time. And charting allows us to do that. There is a big correlation between endometriosis and infertility. It's about 1 in 2 both ways. So about 1 in 2 patients with infertility have endometriosis, and vice versa. About 1 in 2 patients with infertility will end up having a harder time getting pregnant. Because of that, but the only way to know if you have endometriosis is to do surgery. And not just see the lesions, but even ACOG, our American College of OBGYN, says you need a tissue diagnosis. So you have to cut some of it out at least. Our approach is to cut all of it out, but you need a tissue diagnosis to truly diagnose endometriosis. So you need surgery, and the surgery that we do is see and treat. So we look for it, but also take care of it at the same time. But because of the known correlation, up to 1 in 2, of endometriosis and infertility, back in the day, everybody used to get, with infertility, every couple used to get a diagnostic laparoscopy to look for and treat endometriosis. Now, the most recent guidelines by the ASRM, which is the American Society for Reproductive Medicine, they say, which is the National Organization for Infertility Specialists, that it's optional for age under 35. You could do it or not. And then over 35, they want to move you towards IVF because time matters. And I've asked about it, and people readily admit, REI specialists, infertility specialists readily admit, it's not because there's any less correlation of endometriosis and infertility or any less benefit from the surgery. It's because as long as you don't have a big endometrioma in the ovary, which you can usually see by ultrasound without surgery, which might affect their stimulation protocols, they're going to bypass the pelvis altogether. They don't really care if you have the endo and just offer IVF. But again, it's going to be like a broken record, but why not try to find the problem and fix it? Patients feel better. They get answers. It's billable. It can be recurring fertility. So you have to look for these lesions. And it's often, subtle. So there are people that would say endometriosis really needs to be treated by a center of expertise or a center of excellence in endometriosis. On the one side, when it's early stage and there's not much endo there, it's not just black spots. It can be very subtle, non-black spots, brown, red, white, blisters, retraction pockets, peritubal cysts, are all potential manifestations of endometriosis which we feel need to be treated, because if endometriosis anywhere can affect fertility, and even subtle endo, and all those things can be endometriosis, then all of those manifestations of endo should be treated. But it can be very subtle. On the severe side of things, when everything's all stuck, there's big nodules of endometriosis, big chocolate cysts, then it really takes a team approach. And it takes a team. And so often you need a center for endometriosis that has all these parts or all of these collaborations to deal with this kind of severe disease. Hormones are often used to try to prevent endometriosis progression. Does that work? Maybe not. In 2 recent reviews, one done by somebody else and one done by us, we came to the same conclusion that this common recommendation to use hormones not just to feel better, but to try to prevent progression of the disease is better thought of as expert opinion as opposed to really being evidence-based, because it's not. One study that was cited, that we cited, is a series of studies done by a group in France, Chaperon et al. In 2011. They looked at patients who had this more advanced form of endometriosis, or deep infiltrating endometriosis. The mnemonic is DIE, die, right? They looked back at their adolescent history, and they found that patients who used birth control pills longer, more frequently, and beginning at an earlier age, and if you added to that, had a clinical history of missing school or school absenteeism during the period, that they had a higher rate of DIE, of deep endometriosis or advanced endometriosis. So that implies that the use of birth control younger and longer does not prevent getting advanced disease. The way they put it was that the need for birth control pills, longer and earlier for pain, may in fact be a marker for more advanced disease. That was the way they put their conclusion. Does it prevent recurrence? Maybe not. Another often used reason for hormones. What is the real rate of recurrence is actually a very good question, but it's published to be about 50% in 1 to 2 years, okay, after ablation. And that's a quote unquote recurrence. When they added hormones after, this was supposed to be a landmark seminal trial in 2009 where they added hormones after the ablation surgery, which is how most people treat endometriosis. The recurrence rate was the exact same. Hormones also do not help fertility. And all the major organizations say that. People have tried to suppress Lupron for 6 months, or have tried to suppress endometriosis with Lupron for 6 months to try to help down the road fertility, and that has not been shown to be helpful, yet this is tried all the time. Our approach to treat endometriosis is to cut it out. We believe that's a more complete, potentially safer way to treat the disease, and you get a tissue diagnosis, which again is the gold standard to diagnose it. We published a paper in conjunction with a center in endometriosis, in Atlanta, It's the largest prospective study in teenagers. It was small absolute numbers, but still the largest prospective study of excision in teenagers. These are just different kinds of pain. The blue is before, the red is after, so clearly they're feeling better after excision surgery. They describe a better quality of life. But in our study, up to 45% of patients asked for a second look laparoscopy in 2 years. And the reason to do that, to look again, was pain. So that was higher than we had hoped. Now again, they're feeling better, significantly better when asked how is the pain and quality of life. But it gave us a chance to look. When we actually looked, though, the rate of finding endometriosis again, and we took random biopsies, was 0. And we said that if we achieved optimal excision, which we did in the patients, that they did not specifically have to take hormones after surgery to keep it away. So in our study, 2/3 of patients did not take postoperative hormones, and yet still no endo in 2 years. So comparing that with this 50% recurrence after ablation, even with hormones after added. So we believe, and other centers believe, that what you do at surgery is the most important, and that hormones after surgery do little to kind of mop up the rest or keep it away. This also implies that, and to get this, we believe that it's really important, again, to treat not just the typical lesions, but also the atypical or subtle spots. So clearly treating endo is a part of treating pain. That is very important. But our data also implies that maybe we've done something early, if it's not there in 2 years, to help down the road fertility. So this is Padma Lakshmi. She's the host of Top Chef, a supermodel. She had painful periods her whole life. She was told by her mother, who was a nurse, this is your lot in life. She'd be curled up in a ball, had to cancel modeling shoots, stuff like that. She was not diagnosed until she was 35 with endometriosis. By that time, it was very advanced. She had a hard time getting pregnant. She had it cut out. She feels a whole lot better. She got pregnant. And her doctor began the Endometriosis Foundation of America to raise money for research, but also to raise awareness. She would say if she could have been diagnosed a decade earlier, she could have avoided a whole lot of pain and maybe had her fertility better preserved. So she has produced a poster she wants to put in every young girl's bathroom called Killer Cramps Are Not Normal, to tell women, if young women, if you know that your cramps are not like your friends, you're having to, you're curled up in a ball in the fetal position during your period, you have to take narcotics sometimes to get through the period, you have to plan your vacations around the period, you take hormones for pain and do not feel better. That's a big one. These are all red flags, and you should get checked out and checked out early. We presented our teenager data at their study a few years ago, and it was very well received. And we have the same message, which is we'd rather get the endo early before it progresses. And maybe that will help down the road fertility. So So we want some evidence, okay, evidence-based. What is some data we might have for this approach of NAPRO technology? So this is Joe's study, along with Dr. Boyle in Ireland. Over 1,000 couples. The average age of the females was 35. I mean, these aren't really young women. They're considered whatever, AMA, advanced maternal age. So that was the biggest laugh of the talk. Interesting. Mean duration of attempting to conceive was over 5 years. This is really amazing. A third of the patients had attempted to conceive with IVF or some form of artificial reproductive technologies in the past. And yet their life table analysis was over 50% achieved pregnancy within 2 years, with a very low multiple gestation rate, under 5%. Here's another study out of Canada, also Stanford involved. 108 couples, also average age 35 years, over 5 years duration. 22% had tried IUI, 8% had tried some form of artificial reproductive technologies. 66 out of 100 couples pregnant within 2 years. These are excellent success rates, especially over time, 1 to 2 years. So, good ethics is really good medicine. Hormonal suppression is a band-aid therapy, it's suppressive therapy. At best, patients feel better, but it does not diagnose the disease, remove the disease, prevent progression, in the example of endometriosis. ART is circumventive therapy. Restorative fertility care is disease-based and biologically sound. Catholic healthcare should be seen as not just primarily about what we cannot do, but instead, and we need to maintain this focus when we're building our clinics and talking to administrators and everybody, and in talking to patients, really maintain that focus on what we can do, what we do for patients. We talk about cooperative medicine and restorative surgery with excellent outcomes. So at SLU, we try to offer patient-centered, comprehensive services. So we have a Center for Endometriosis, which I lead, which is really trying to cut out, the fundamental philosophy is to remove or excise the disease. And we do that for pain and for fertility. When you treat the disease, pain improves for the most part, and fertility chances also improve. On the pain side of things, though, as we saw in our study, there are oftentimes other things that have to be treated as well. Treating endo is only one source of pain. So we have a pelvic pain center to help address and treat all the other non-endometriosis sources of pain. And that's been really helpful. So in our study, when I was at Duke, our rate of repeat surgery was 45%. We did not have a pelvic pain center there. Now, with the pelvic pain center, we keep our own data. Our rate of repeat surgery is 6%. That to me is a real testament to the importance of treating the other sources of pain. And it's multidisciplinary. We have urogynecologists, GI doctors, pelvic floor physical therapists, all of that there to help address the non-endometriosis sources of pain. And then we talk about how on the fertility side, again, treating endo should help fertility, but we have this restorative fertility clinic to help optimize the non-surgical conditions and environment to help patients get pregnant together as a couple without IVF. So let's see if this works here. I cannot say it better than the patient, so I think I have some time. I'm going to try to play this here for you.
My husband and I decided we were ready to have children, so we started out, like every couple does, just trying naturally, and after about a year of trying, we still were not pregnant. So our first stop was a fertility specialist. They basically told me that I couldn't get pregnant naturally, that I had to have help.
They basically said our only treatment was IVF at that point. We obviously both wanted kids, but the amount of money that it takes to do IVF is obviously a deterrent.
We did our first round of IVF, and it failed. Try again. Obviously it cost a lot of money and it was heartbreaking. So at that point in time, I really just took a step back and I said, I still don't know why I'm not getting pregnant naturally. Nobody's ever specifically told me the answer to that, and that bothered me.
I looked at her, she looked at me and said, we need a different route.
A family friend of ours told me about NAPRO technology and how it is basically the natural way of figuring out why you're not getting pregnant.
We were a little skeptical to the fact of we didn't really know what it was, but we were willing to talk. So we went to Dr. Yeung.
I remember meeting Megan and her husband, and just a beautiful couple, but could kind of tell, like a lot of couples who have been through infertility, that they had a hard time and a rough experience in trying to get pregnant. Infertility can be tough, and that it can really drive a wedge between a couple. When I describe the approach of the Restorative Fertility Clinic, which has a basic approach of trying to basically find the problem and fix it, like in every other field of medicine. That's that simple kind of presentation. You could see, like, they kind of light up. They really connected or resonated with that approach. That was kind of something I think they felt was missing in their treatment plan or approach in the past, and they were excited about that.
He took a look at whether or not I might have endometriosis, and we decided to move forward with a surgery. And after the surgery, we continued to chart and try, and he kind of guided us through that.
We did some more blood work, and we found some more issues, low progesterone, other things.
I didn't know any of these things, amongst many other things, when I was trying with the fertility doctors and we did IVF. This was very eye-opening. These were answers to my questions. These are the things that are wrong, and it's as simple as taking over-the-counter pills or a few prescriptions. I think this was the only way that I had come across that was going to give me answers. It was a slower process. It wasn't immediate gratification, and that's always hard to swallow when you want something so badly, but it was going to give me answers, and I wanted answers. First month with all the medications and everything he had us do, we found out we were pregnant.
They thought it could never happen. They kind of thought, I think IVF was their last hope. And then when that failed, I think a lot of their hopes kind of were dashed. So when they achieved pregnancy, it was such a beautiful thing to be a part of, and we're thrilled.
I don't feel like there's anything better than getting, that pregnancy test that says you're pregnant at a surprise. So. Every day when I come home from work, it's the best feeling in the world. I mean, just seeing her change and just talking to other people about being a dad, and just seeing her face and how she changes every day. I mean, there's nothing like it.
Every single day, I thank God for her, and I thank God for the doctors who have figured this stuff out, and being a mom is indescribable and amazing.
Oh. Yeah, that was very humbling. St. Louis University has been very supportive of us, and we do have now this NAPRO, or Restorative Fertility Clinic. We teach medical students and residents. The medical students are exposed to a talk on fertility awareness-based methods. The residents, in their training as a part of their core curriculum, the residents are welcome to come and attend and learn through this NAPRO clinic. We have several fertility care residents in our residency program. So it is possible to have a very viable, thriving clinic, even in an academic setting, and have that be a part of resident and student education. This was humbling, but I do tell patients, and I'm open with patients, that we're all in this together. My wife and I, we tried to get pregnant from day one. After a year of trying, my wife had had painful periods her whole life. My wife said, maybe I have endometriosis. I said, no way. And she ended up having bad endometriosis, actually stage 4 or severe endometriosis. Had surgery, had Gore-Tex for adhesions, other non-surgical optimization. So we adopted, and then she got pregnant. And then we were going to adopt again, and then she decided to have Gore-Tex again, and then she got pregnant again. And then we got pregnant one more time recently. So I have 3 girls and a boy. So, but we are all in this together. Another benefit of being an academic, and I say a benefit really, because it can often seem like to be an academic can be limiting or restrictive, is research. And we keep an ongoing database, and we can do research. And whereas on the one hand, you know, when you're in an academic setting and people are always talking about evidence-based medicine or an evidence-based approach, well, the evidence has to come from somewhere, and you can do anything, or you can do things in a research protocol and collect that evidence. So under a research protocol, you can do cutting-edge things. And again, that is how we move the field forward and publish on that. So this is iNest, which we were a part of, which is active but not recruiting, and other things are happening as well. Also, and that'll be mentioned I think later on as well, you know, you can talk about doing a quality assurance or quality control study or project where you look at your data. So we're trying to collect all the data, but then this can be described or published on. So again, I leave you with good ethics is good medicine. We really want to believe that, show that when we talk to patients and our colleagues and our administrators. Catholic medicine should be about what we do, not just what we don't do. And we should try to show that is good and true and beautiful and with joy. I don't think the goal is necessarily to try to show people that they're wrong and we're right, or to have whatever 10 kids and be miserable. It's to do so with joy. And I'll leave you with one last thought. I heard once, we don't treat patients because they're Catholic. We treat patients because we're Catholic. Thank you.